glargine group. But if you look at the nocturnal hypoglycemia, that was naturally a little more in the glargine group. That is understandable. You are going to give insulin at bedtime. Sometimes sleep time hypoglycemia occurs. But again, this was not statistically significant. So the overall hypoglycemia was not different between twice daily premixed insulin and the glargine given at bedtime. So this study concluded that this is the combination insulin given twice a day is associated with significantly greater A1C reduction at the endpoint, enabled a larger proportion of patients to achieve target A1C, that is less than 7, improved glycemic control after breakfast and dinner. That is very important. Your basal insulin given at bedtime may control the fasting, but may not control the postprandial excursions in blood sugar, and result in higher overall hypoglycemia rate, but similar in nocturnal hypoglycemia. And mixed 25 provides optimal insulin starting regimen for patients, because this regimen is very simple and the patient can intensify later from 1 to 2 to even 3. So what we arrive at the conclusion, the premix combines rapid and intermediate acting insulin, effectively control both fasting and postprandial, and that is very important in the Indian context. It achieves A1C reduction comparable to even basal bolus insulin. I will be showing you some more data to show that even compared to basal bolus, where you cover each meal with a bolus insulin and give basal insulin once or twice a day, this regimen is better, and then typically given once or twice daily. So the number of injections compared to the basal bolus, where you give at least 4 injections, is much less, and simple schedules of fewer injections, same type of insulin given in the morning and night. So the complexity of regimen is also removed. The patient can easily follow it. So who are the patients who are suited for this type of insulin? So individuals with typical Asian Indian phenotype, where the carbohydrate content is very high, the postprandial excursions are very high, where basal alone may not be enough. So such patients may be started even at the initiation of insulin with premixed insulin. Patients who prefer convenience, the same insulin morning and night, so that can be given both in the morning and night. That is also another reason why you should choose premixed insulin. And there has been a delay in starting insulin, and the risk of failure to basal insulin is very high, because the patient has been diabetic for 10 years, 12 years, have been remaining in poor glycemic control for long periods. It is very, very unlikely that he is going to be controlled only with basal insulin. So the duration of diabetes, longer the duration, then it is always better to start a premixed insulin once or twice a day. And prolonged uncontrolled hyperglycemia, I have already alluded to that. Symptomatic diabetes, where the patient has got symptoms of diabetes, polyuria, polydipsia, then vulvovaginitis or balanitis, all those cachexia. So those patients are suitable for premixed insulin twice a day. And whenever there are associated comorbidities like diabetic foot syndrome, again, these patients are suitable for premixed insulin. Lifestyle.
Thank you, sir. The time is up.
Time is over? Can I take 2 or 3 more minutes? Okay. So irregular meal patterns, high carbohydrate load, all these patients are very suitable for premixed insulin. So this is again about the focus of today's talk, insulin glargine versus insulin lispro. This was again a durable trial. The results were published very recently. Compared the lispro mix to glargine. Again, you can see that the change in A1C from baseline was better with lispro mix compared to glargine, and the durability of the combination was also much better compared to, durability is very important, how long it maintains the A1C target. So these are all the, so what we have come to the conclusion is that LM50 is better, it reduces the postprandial sugar. Bedtime blood sugar is also reduced when you give twice daily mixed insulin, and the mean SMBG excursion, which ultimately leads to glycemic variability and poor time in range, is also better taken care of by a combination of short-acting and long-acting insulin. Then there is always a question, what about 50-50? Yes, sometimes you can also use 50-50 in the morning and 25-70 in the night. Suppose you feel that the postprandial hyperglycemia is more with breakfast and lunch. You can always give 50-50 in the morning and 25-70 in the night to control the fasting hyperglycemia, and also to avoid the nocturnal hypoglycemia, because nocturnal hypoglycemia is very serious. It can even result in cardiovascular morbidity and mortality. We want to avoid nocturnal hypoglycemia.
Sir, final concluding.
Shown. Thank you, sir. Thank you. I think last slide, sir.
Yes, sir. Final concluding.
I'll come to the conclusion.
Yes, sir.
So this is again the quality of life about the two combination. Again, it showed that the quality of life is good with premixed insulin. And at least the last slide, switching from basal insulin to premix is a viable alternative to adding prandial insulin, simpler than basal bolus, and suitable for patients unwilling or unable to manage the complexity of the insulin. And these are all the recommendations by the world bodies. The ADA, the IDF, and our own RSSDI says that if basal insulin is alone is not enough to achieve A1C target, you can always go for premixed insulin. I think this is the last slide. Thank you. Summary, patient-related advantages, simple to understand, no complex carb counting and isolated, 1 point pen for both basal and prandial insulin, fewer injections, and less frequent intensification. So there are also certain physician-related advantages. Thank you very much.
Thank you, Professor.
Sir, thank you, Dr. Madhavan, sir. Thank you very much for explaining vividly, sir. Thank you very much.
Yeah, we can move on to the next topic, sir.
I call upon the next speaker, Dr. Arun Kedia, who will speak on diabetes and bone health. Welcome, sir.